coming. Welcome to another London lecture brought to you by the Royal Institute of Philosophy in this year's series, which is entitled Madness and Mental Health. So now, without more ado, let me introduce this evening's speaker. It's a great pleasure to have with us this evening my colleague, Professor Kam Bhui. Kam is Professor of Psychiatry at the University of Oxford, where he's also Senior Research Fellow at Wadham College, and he's an honorary consultant psychiatrist both at the Oxford Health NHS Foundation Trust and at ELF, the East London Foundation Trust. He has a wide range of interests and a wide range of publications to match, including on the role of adverse childhood experiences in the onset of mental illness, multimorbidity, and social and racial inequalities in mental health. And he's a long-standing champion of public health and epidemiological approaches to mental health, with perhaps, hope I'm not getting this wrong, a special emphasis on the importance of cultural competence and the elimination of health inequalities. And his paper this evening is entitled Ethnic Inequalities in Experience of Mental Distress and Illness and Care. Kam, over to you.
Well, thank you very, very much for inviting me to give this lecture. It's a great honour to continue your series on mental health. Thank you for turning up on this evening and taking time out to hear a bit about a topic on which I've been grappling for 20, 30 plus years actually. It's not easy to talk about ethnic inequalities in mental health care or have conversations about injustice, race, mental illness. They all require some thought and reflection. There are contested vocabularies, contested concepts. The findings are often not believed. The evidence base is growing but is still insufficient. Discussion can often provoke distress, discord, unexpected feelings, criticism, and even hostility because of felt injustice and identifications with powerlessness, or indeed the opposite, a sense of indifference and opposition to what's considered progressive, a sense that what we talk about is too political and trivial and inappropriate. And you may have all of those feelings all in one go this evening. I assume a third of the audience disagree with me, whether they want to admit it or not, so there's plenty of opportunity to discuss and debate by the end of the evening. But I do ask you to be careful with any tweets or distributions of what I've said out of context, because the way people receive these messages in a fast media without context can provoke distress and all sorts of difficulties and discord. And so hopefully we can put some of that right in the discussion where we can have plenty of time to consider these concepts. I'm aware it's a public lecture. Some of you may be specialists in the area, but the majority, I presume, will not be familiar with mental health systems, and I will try and explain as much as I can as we go along and unpack concepts. Although I hope it will not matter too much that you're unfamiliar with mental health systems, and I hope that we will be able to reflect on some of these issues as ahistorical. Debates about mental illness and how to care for people with mental illness have gone on for centuries, really. We often gather our understandings of mental illness through communications, the media and film, and it may be where you get most of your images from and most of your concepts. I don't know. The public certainly appeal to films far more than reading books and coming to lectures, actually. So thank you for coming to listen to this today, because there are plenty of films from which you could also learn a great deal. Whether you learn about insanity from Macbeth, about grief and vengeance, or whether you learn from a popular film, One Flew Over the Cuckoo's Nest, which included Jack Nicholson playing Randall McMurphy. He arrives at the State Psychiatric Institution at Salem in Oregon, having persuaded them he's insane, having been sentenced there for rape of a 15-year-old. So this brings up notions of criminality and criminalisation and the tension between insanity, defences, which is topical at this current time. He clashes with Nurse Mildred Ratched, who's cold, punishing, heartless, a tyrant, and uses privileges and medication to control the inmates as well as the staff. He surprises her by wanting to go to a baseball game, and she restricts the conversation by saying it needs to be put to a vote and it will disrupt some people. And he ends up taking a vote, and of course nobody wants to go to the baseball game, which surprises him enormously, considering it's something he really wants to do and has been doing annually. Something he hadn't expected, a privilege he expected he would have access to in a hospital rather than in a prison. The battle between them continues, and it gets darker and more disturbing and harmful to both of them. So the film illustrates institutional power and raises many questions about criminalisation and mental illness and the relationship between the two, which is very much relevant to the notion of ethnic inequalities that I'm going to be talking about. A Beautiful Mind by Russell Crowe was more gentle and anti-stigmatising, offering a sympathetic portrayal of psychosis and the potential for recovery. A mathematician, John Nash, arrives at Princeton and works on publishing his original thesis on governing dynamics of cooperative play in games. He moves to MIT, where he survives a paranoid psychosis. He realises his roommate's niece, and a Secret Service operative, William Parcher, for whom he thought he was breaking codes to thwart a Soviet plot, were not really aging and were not real. And eventually he manages to survive with medication and keeps his marriage going, and even wins a Nobel Prize and a lot of esteem from his peers. Another favourite of mine is Akira Kurosawa's film Redbeard. He's most known for Seven Samurai. He's done a lot more than that and a lot more powerful stuff than Seven Samurai. He's written a lot on poverty, life and death, grief, insanity, and the role of doctors. Toshiro Mifune plays a doctor, Kyoja Nide, who's called Redbeard, the film title. His training as a samurai comes in handy when he is attacked by a bunch of thugs who want to take a young girl back into prostitution. He's rescued her. He breaks their arms and legs and concusses them, and in doing so laments that doctors should not have to behave in this way, and afterwards asks his assistant to attend to them. In another episode, he blackmails a senior official with information about his mistress, and ultimately ends up securing accommodation for a destitute mother and child by blackmailing this politician. And it reminds his trainee to remind him, if he ever becomes arrogant, of his failings in life. He struggles with these ethical dilemmas of power and poverty and abuse and the law and how it doesn't really help, and powerlessness. And he's persuaded that his idealist moral values are powerful and should be followed. So these films portray all sorts of traditional hierarchical perspectives. Some are heavily stigmatized, some of course have changed. We don't do unmodified ECT anymore, for example. But of course, you may consider that these are so historical that none of the learning from these films applies today. But I'll let you decide that by the end of the presentation, when you hear a bit more about some of the lived experiences that people have of surviving in our system of mental health care. So with that brief introduction, I come now to my main topic, which is a problem that I grappled with for 30 odd years, and how it's been addressed and why we haven't really succeeded in addressing it, where there's been resistance, what's been missing from the proposed solutions. And I want to propose a suite of other solutions which take lived experience into account by presenting you with some projects and some research data from a project called COPACT. I'm going to start with a psychosis story. This was my first experience of working with someone with psychosis as a medical student. I was privileged to be working with a very enlightened Professor Jim Watson back in the 80s, and his way of teaching medical students was to get them to do some work, sending them out with patients, saying help them through the social challenges they face, look at where they live. And I've always remembered this young black man who was sleeping under the bridge at Walworth Road. He was supposed to have this thing called schizophrenia. I couldn't tell as a medical student that he had anything actually, and I suspect, looking back, I don't think he did. He had destitution, he was homeless, he was sleeping on the street, he needed benefits. And there are, of course, diagnoses in schizophrenia that would fit with negative symptoms and withdrawal, but I'm not sure he had, and I think the medical diagnosis was being used to offer some sort of social support. He was later admitted and provided with support. And then throughout my training, I've seen, particularly in London where I worked for most of my life, black patients dominate the wards and the inpatient services and the crisis services. I became very interested in cultural psychiatry and social psychiatry and worked with sociologists and anthropologists and increasingly with philosophers and ethicists trying to work out what we were doing, why we were finding these inequalities in the incidence of this thing we call psychosis. We have some of the highest rates of psychosis in the world in London. And they vary enormously across the country and across Europe. In 2005, there was a first national policy on preventing ethnic inequalities in experience and outcome of mental illness, delivered partly through a policy called Delivering Race Equality. They developed a race equality and cultural competency framework. This became quite challenging because in the middle of the programme, there was opposition to the idea that there might be this thing called institutional racism, that somehow people felt accused of doing something terrible and of being prejudicial and individually racist, as opposed to treating a need for care that people had with this symptom pattern that they presented with. So psychiatrists, some of them, not all of them, were a very large group, lobbied against it, and the Department of Health, in the middle of this programme, decided to ban the word racism from the vocabulary of policy documents. And the programme was foreshortened, and then there was silence for about 7 years when nothing happened. No one was talking about it. The same data were being produced. No one knew what to do about it, but it seemed improper because it wasn't a priority anymore. In 2017, I led the Synergy Collaborative Centre funded by a charity, and interestingly, they were only interested in the values and the processes by which we were working. They didn't want metrics and outcome data. They didn't want us to prove that anything was going to work. They were just interested in us tackling the problem and having the right values and having the right processes in place. So this is unusual and would probably not have happened through the statutory sector. The programme closed in 2022, and I'm going to say a little bit about it later. But again, that suddenly opened up people's eyes. Of course, this was pre-COVID and Black Lives Matter, so it allowed us to prepare for what we didn't know was going to come to us, this dystopian reality we all faced. And suddenly all these materials were ready for people to be used. We had some opposition at the beginning, but suddenly people wanted to use our materials. And they were made use of in the Royal College of Psychiatrists' statement on racism, which again was a contrast because back in 2010, the academic faculty of the college had opposed using the word racism in all policy documents, so a major transformation. And now there's a major equalities programme taking place. In 2018, there was the independent review of the Mental Health Act. Again, they reinforced the findings of over 60 years of data that there are ethnic inequalities in experience and outcome, in particular of detention, black people being detained 4 times more often as white people. And these data haven't changed for a very long time. At the same time, there are cultural psychiatrists and WHO and the American Psychiatric Association grappling with this thing called diagnosis, trying to better understand what it means, trying to improve it, make it more scientific, do some field trials. And within that effort, there were the rumblings of a recognition of culture and ethnicity and race being relevant. So the cultural interview was born, and various efforts were made to include something called the cultural formulation and continue it. This work is still in its infancy, it's being evaluated. And more recently, the Race and Health Observatory opened. It's working not just on mental health, but on all sorts of conditions, perinatal mortality, there are 4 times mortality rates in black women, for example. So there are real problems in our health systems if there are these inequalities. This is what's supposed to happen when someone with mental illness needs help. They're in the community, and they gradually work through these series of filters through their GP. They're recognised and provided care, and if it's not sufficient, they get referred on to specialist care. They can be referred back into the community if the GP doesn't recognise any illness. African Caribbean patients tend to come into the service through the forensic system, directly to inpatient care in crisis, either through the police or through emergency provisions in A&E. If they're recognised to have a mental illness, African Caribbean patients are also referred through to specialist care faster and more often. They're not held in primary care. In contrast to South Asian patients, broad categories, all contested. We can talk about that in the discussion, who tend to remain in primary care with the GP, with the primary care team, or get referred out to community care. So these broad patterns have continued. I did a systematic review in 2003. I did another one in 2018. Exactly the same findings. They're pretty consistent. What's been tried? People have really looked at this thing called cultural competence as a solution, that somehow the problem lies in the interaction between the clinician and the patient, that the patient has variations in the way they present symptoms, the way they express distress. Their worldview might differ, and we need not to stereotype and misapply scientific knowledge, but to obtain cultural information and then apply that knowledge. See the entire picture, have some flexibility and respect for other viewpoints. We know illness beliefs or perceptions of illness or explanatory models, they're all different words from different traditions, different disciplines, meaning the same thing, that culture does change the way we express distress, the way we understand causation. The idea is to improve our individual personalised interventions and to acknowledge some complexity in healthcare. Understand help seeking might vary across cultural groups, ethnic groups, racial groups. Develop the knowledge, the ability and knowledge to communicate, understand health behaviours that are influenced by culture. To eliminate barriers to healthcare delivery and to help healthcare organisations to develop policies and practices and procedures to deliver a culturally competent care. This is an old paper, 1989. Cross and Barron produced a definition of cultural competency which include valuing diversity, the capacity for cultural self-assessment, being conscious of the dynamics when cultures interact, institutionalised cultural knowledge, and develop adaptations of services reflecting understanding of diversity. So back in 89, Cross and Barron was saying you also need to consider policy, administration and practice. It's not only about the clinical encounter. That, I'm afraid, is not really what's been happening. Most people have continued to focus on the individual clinical skill set and what the clinician does with the patient. Cross and Barron's model also includes this schema that organisations can move between being destructive, incapable, culture blind, which most organisations claim to be, pre-competent, which some organisations reach, competency and proficiency. And really my main thesis is that unless the organisational and systems are, organisations and systems are cognizant of this dimension and are working to improve their pre-competency and competency, it almost doesn't matter what the individual does in a clinical setting, and I'll show you examples of that a bit later. Why has it not worked? There's been this very narrow focus on individual illness, on treatment and care. And of course, when someone becomes unwell, there's a long journey before they actually come to the attention of services. Diagnosis is contested, and there's a whole debate about, do we call this thing a disorder? Do we call it an illness? Do we call it a distress experience? I quite like the word illness because it reflects the individual's experience, after Leon Eisenberg's writings, as opposed to disorder, which isn't really very sympathetic, is it? But it is part of the medical system. And if you go to court, you're meant to say which medical disorder someone has. Telling them they've got an illness or a softer version of it doesn't really count in court. You've got to be quite firm in what you say. There are these wider institutional and societal and political and historical perspectives in concepts of care and mental illness. New words, ecosocial and syndemic frameworks, which I'll try and unpack a bit later on, but bear with me. Essentially, all that means is we're expanding our lens not to look only at the individual, the embodied individual, and their experience of distress, but the wider systems which lead to that distress. Clinical interactions have been reformulated. There's lots of regulation. There wasn't the GMC in the Tokugawa period in Japan when Kurosawa's film was made, but we have a regulator. We have lots of professional training. We have lots of checks and balances. Every time there's an atrocity of some sort or a failing in the system, more regulation gets put in. And still, the data don't shift. So what affordances does a system produce that means nothing changes? That's something we have to interrogate. One of the concerns I've had is that workforce representation, as important as it is is often conflated with improving outcomes for people, improving their lives, improving experiences. Of course, we need to recruit people with the right backgrounds and the right cultural beliefs. But if they're trained in the same way, if they're regulated in the same way, they're not going to change in their behaviours. Their behaviour is going to be identical. Because if they do depart, then they're violating their codes of conduct and their professional trainings and practices. So it's very difficult to be flexible. Although cultural consultation, a model that I'll share more about with you later, cultural competency frameworks that are now evolving, require some flexibility in the way we think. Then epistemic injustice, I'm going to unpack that also for you a bit later on. So thinking about clinical communication. I'm sorry about the colours. On my screen, I've got these beautiful contrasting colours across the screen, but you've got this bland set of colours on the screen, so it's difficult perhaps to see the differences. But not only are we dealing with this central circle of clinical interactions, we're talking about primary care and community assets, we're talking about health literacy, people's explanatory models, their help-seeking behaviours, their identity, their sense of self. How do they experience distress? Do they experience it individually, in an embodied self, or in a community as a we self? There are other variables like demographics, age, gender, acculturation. Have their health beliefs shifted over time? Religiosity, all sorts of things are going on. And then there's what happens after the clinical interaction. Are we able to provide reasonable care? If people don't fit, what happens to them? Do they fall out of care? What if they don't fit, but we're a bit worried about them? Is there an escalation of care? Are they on the escalator to more coercive care and end up in the forensic system to be criminalised? And if that sort of dimension isn't complicated enough, even this thing that we call mental illness has many, many different manifestations and components. From this normative distress that we all have at various times, when there's too much rain, when we've been bereaved, when our children don't listen to us, when we're in conflict with friends and loved ones. That's distress that is part of human life, and that can get conflated with emotional distress needing clinical care or help. Then this thing, anxiety and depression, has overused to some extent. Self-awareness campaigns have been very helpful, but perhaps we're over-applying those terms, thinking of clinical care concepts rather than necessarily these being normative experiences that we can manage through our self-care processes and through public health interventions. But of course, it's difficult because when you're in distress, and if anyone who's had extreme anxiety or has been bereaved, your sense of fragility and threat perception escalates. You walk around seeing the world as an unsafe place. And there's a continuity with what this thing called psychosis is. About 10 to 17% of the population at any one time experiences psychotic symptoms. They're not psychotic, they're not got a disorder, and they restitute. And this level of common psychotic experience varies with urbanicity, with distress, with vulnerability and adversity. So we know there is a pathway, and we're trying to understand what that pathway is. I want to expand that even more to say that diagnosis itself doesn't really take account of all the other complex influences which lead to mental distress and ultimately move people along that continuum. So we know adverse childhood experiences, social class, poverty, neurodevelopmental problems, multiple disadvantages. It's particularly bad for people living at the intersections of multiple disadvantage. Discrimination, gender disadvantage, violence, criminalisation all lead to poor health, as well as all those demographic factors that I've talked about. Also, historical experiences of racism. What you experience in your childhood determines your health in adulthood. If you've had more than 4 to 6 adverse childhood experiences, you have a shortened life expectancy. So you will develop long-term conditions when you're older. What about historical adversity? What if you've got a history of slavery in your family? What if you've got a history of genocide? What if you've got a history of being a refugee in your family? How does that affect you? What latent identities are there? What cultural violence is transmitted through parenting that might be re-invoked when you have an experience of distress? None of our current diagnostic frameworks or care practices fully accommodate this level of complexity. So this is where I draw on the anthropologist Meryl Singer's view that we need to talk about syndemics, multiple co-occurring epidemics, and understand the social and political context. And Nancy Krieger has expanded that framework, although she was there before Singer, around the same time actually, looking at eco-social frameworks, she calls them. She wants to consider the wider political and historical features that I've alluded to in the generation of distress and mental illness. When you put those two together and you think about this more complex framework and then you ask a clinician to do something, it gets very complicated. They've got to think about the context and the environment, their assessments expand, their interventions have to be complex and thinking about history. They've got to be really smart and skilled and be learning very fast with every new cultural group that they encounter. Research also has to be more complex and structurally competent. We need to think more about epistemic injustices in research. And then, of course, there are new horizons. Climate change is a real worry at the moment. We know urbanisation is linked to poor equality. Poor equality and climate problems are indeed linked with poor mental health. And there's emerging evidence that we need to be reducing the levels of pollution to reduce poor mental health and poor physical health. So I will draw on eco-social and cultural syndemic frameworks throughout, and you may want to reflect on that in the experience data that I present. There's this additional problem of a distinction between mind and body. It's a fallacy. All of these adversities, this exposome is the word being increasingly used, affects your mind, your brain, and your body interchangeably. There is a reverse causality. If you have cancer and you have depression on top of it, you have a high mortality rate. You need to treat the depression. If you have depression and your lifestyle isn't good, you're likely to develop long-term conditions. So this is really important to think about, and we haven't really thought about it. Then there are additional challenges, systems and organisational limitations. The diagnostic frameworks built in the States were really built for billing purposes, not for care. How much do you charge? How do we compartmentalise this? And unfortunately, we've learned a lot from them. We've learned to add diagnosis to our commissioning frameworks. Fortunately, the DSM and ICD-11 have continued to work to improve their diagnostic frameworks, but ultimately that's still part of their purpose, to serve commissioners to better understand what we have to do as a system and who gets seen in places like the NHS. They do reward simplistic models of illness and a simplistic response. If you worked in any organisation, you know how difficult it is to adhere to any complex framework of policy intervention. You need to be simplistic in order to leverage commitment. Financial and bureaucratic mechanisms and metrics themselves are simplistic. And sometimes these bureaucratic priorities, these perverse incentives, dominate our care systems rather than what the clinician thinks or what the patient wants. We somehow lost those personal connections where clinicians spend more time pumping in data on the computer than necessarily they do spending time talking to people and doing what they were trained to do. And of course, the system has to comply with state regulation. It's designed to address emergencies. It's really well designed to address emergencies, but not necessarily to provide support and care and preventive care for those with long-term conditions. Those perhaps who aren't going to be economically that active, maybe they don't vote, maybe they don't have a home, or they don't stay in one place for long enough. It's not really designed to support those people. And then there's more conscious resistance and denial that one comes across in doing this work. And I've had patches of this over decades. There are always conflicts and disagreements. Is this really a priority in the NHS? Isn't everyone's care important? Everyone has non-negotiables. Nobody wants to give up power or resources. No one wants to merge organisations to do the right thing. We don't really listen particularly well to each other. We assume the person has said something we agree with, and therefore it allows us to action our frameworks and our policies rather than really listen to disagreement. Systems reform is hard. If you've tried it, if you're in the system, it's really difficult. There are multiple layers of uncertainty. You have to live with uncertainty on a daily basis, and if there are big budgets involved, you worry about those things. There's quite a lot of resistance and unthought action. I've heard all sorts of things like, we have enough black staff, we don't need additional training, thank you very much. not borne out from my experience. And often those black staff are in the lowest grades and the least trained or on temporary contracts. So it doesn't really work that way. They're not in leadership positions. And if they are, they're put under the microscope and they're given additional tasks, like be in charge of EDI, with no resources to help them do that. They're somehow magically meant, because of the colour of their skin, magically meant to be able to fix this problem, which has gone on for generations. Another one, contempt. When people feel disempowered, contempt emerges. If I see an Eskimo, I'll call you. Someone's actually said that to me. It's quite extraordinary, really, isn't it? We do it anyway, don't we? Why do we need this additional work? Don't we look after people? We're all trained to do this. We're race blind, we're culture blind. You're saying we're racist, that's not right, and so on. And so there are all sorts of narratives of protest, if you like, or that generate conflict. And there's nothing worse than putting off commissioners and organisations and policymakers and politicians if there's conflict, if we can't achieve a consensus, if there isn't some sort of prioritisation. I'll tell you a bit about how we've tried to tackle that, not perfectly, but I think we've made some headway. This is Doreen Joseph. She's worked on some of the research projects with us. She talks openly about having lived experience of paranoid schizophrenia and having been admitted to hospital at times for perinatal mental health problems. I've had a great pleasure in co-authoring a chapter with her in this volume, Mind, State and Society. And we talked about the social history of psychiatry and mental health in Britain between the 60s and 2010. And these are the words she used from her experience: victimised, pathologised, invisibilised, criminalised, marginalised and demonised. And she sets out the evidence for each of those and talks about that through the book. So I do recommend that to you. And it's not all heavy. We also laughed when writing the book together. When we look back at comedy in the 60s and 70s and 80s and right up to 2000s, there were racist themes that we all laughed at together. And I remember growing up watching an 8 Half Hot Mum of Indian Sikh heritage, and it was modestly funny. It was connected my parents with something they hadn't seen for a long time. But with hindsight, it was probably not appropriate or right, and it was a way of laughing at ourselves to take some sort of control over a difficult scenario. And all of these shows, if you look them up, they have funny moments, but they're difficult to watch today when you look back at them. And this is a really nice book by Peter Barham, who talks of outrageous reason, how reason has failed us. That if you look back at the psychiatric institutions and slavery and colonialism, they're all linked, they have a shared history. Psychiatric diagnoses and the institutions have been used to reinforce colonialism and slavery. And he gives very detailed examples. When I first opened the book and I thought he was making these links, I thought, I've got to see this. I don't know how he's going to do this. But after reading the book, I was pretty convinced. And he gave very detailed historical examples, in-depth events with sources, with source data. One example I've known about for many years, drapetomania. That's when a slave, if they wanted to run away, they had a condition that was called drapetomania. And the treatment was you chop their leg off and they couldn't run away. Now, this is quite an extreme thing to say, but I guess it shows how atrocities and inequality and discrimination and prejudice and violence can be legitimised through legislation and through our cultural milieu. I mean, indeed, even through COVID, we've suddenly woke up to all sorts of historical disadvantages that we've been unaware of, and people became aware of data that should have been known. The bit I struggle with in Peter Barham's, what's going on? Book is Afro-pessimism, and I'll leave you to read about it, but it's almost a nihilistic account of how black people are supposed to survive and can survive given the conditions in which they're expected to survive. One of the last reasons for why it's challenging, and I'll expand not on the reasons why it's been challenging and things haven't worked, but on what might have worked and I think has worked, is epistemic injustice, a term coined by Miranda Fricker. I'm attempting always to not use jargon and not use concepts, but the problem is, without concepts and without thoughts around concepts, it's difficult to articulate some of the challenges that people have faced. So testimonial injustice is when someone, on the basis of their identity, their skin colour, their diagnosis, their heritage, is not heard and not listened to. I mean, you may have had this experience. You're listening to someone who you disagree with. You literally can't hear them, or you can't make sense of what they're saying. And it doesn't go in, and someone else has to tell you what they said later. Or they say it and no one says anything, and then somebody else says exactly the same thing, and it's applauded. So testimonial injustice, it's a real phenomena. I'm also a psychodynamic psychotherapist, trained as one, so I'm interested in this phenomena of how you communicate, how we listen to each other. Then hermeneutic injustice reflects when structures and processes of knowledge production are flawed and biased and omit lived experience. The importance of that is we don't have the concepts and we don't have the vocabularies even sometimes. And someone has to invent them, and that's what we're in the business of doing at the moment, I think. And then thirdly, and this is the bit I've added, that our work has to be trauma-informed when we're trying to work with people. Should we be surprised they're unable to hear us, if they're distressed by what we say to them, if we disagree with them, if they're detained, if we're not taking account of what they say? There's a lot of work on trauma-informed care at the moment and the need to avoid re-traumatisation, but it's still not significant enough. And Edward was kind enough to mention our work on adverse childhood experiences. We're trying to develop more trauma-informed ways of supporting young children who have faced adversity. Using, interestingly, public health resources, and also trying to develop serious games. So moving to things that might have helped, I think, or where we've tried to shift the dial. And it's always in the interdisciplinary context. So cultural consultation is a model of care which was developed at McGill by Kiermaier and colleagues. And it draws on anthropology and ethnographic principles of communication and understanding power. And it was adapted to provide a consultation service originally at McGill, and is being used in several cities around Europe and around the world. We adapted it for a service in East London, which ran for about 18 months. We had about 1,200 referrals. Most of them were resolved through discussion with the referring team, or the carer, or the patient. About 40 were requiring a more in-depth consultation where we used ethnography effectively and elicited explanatory models. Headline data, broadly speaking, people's functioning improved. There was a saving of about £500 over 3 months per patient. It's not big enough for commissioners, but there was a saving. Clinicians found it helpful. There were changes to the treatment plan. It improved engagement. There was an earlier discharge. 45% wanted more cultural consultancy. But there was a lack of resources to implement the recommendations of any consultation. Now, I thought this was great, but it wasn't great enough for it to be adopted. Although we were saving money, you had to spend money to save money. And really the anthem at the time was we need to spend less and save money and still do the same job. So it's a real challenge for us. Again, very contemporary in the debates we're having about austerity being a financial necessity or a political necessity. I mentioned the Synergy Collaborative Centre earlier. I learnt a lot from this. It was a very challenging process. I worked with colleagues in Manchester, James Nazir and Joy Francis at Words of Colour. Words of Colour is a communications agency, and that was very important because we had to think very hard about our vocabularies and how we engage people from diverse communities through art, through theatre, through poetry, through different forms of communication. We foregrounded experience data, used co-design and participatory methods. We found ways of disarming people and leaving power at the door by not meeting in large halls or theatres or university buildings, meeting in galleries or community venues. Surprisingly, we discovered that the most important ingredient was collaborative leadership, allyship with our colleagues who were trying to do this work, rather than doing the implementation ourselves. And creating spaces where creativity flourished, a bit like the cultural consultation model. People could talk about these things, feeling safe, feeling they could say things they didn't understand, disagreeing, forming a coalition despite disagreement, sometimes marked disagreement, very divergent ideologies. And then improving the basic literacy everybody had, because despite me saying we've known this data for 60 odd years, people didn't know the data. Clinicians didn't know the data, patients didn't know the data, policymakers didn't know the data. It was no good saying you haven't seen the data for 60 years. It's not a very inspiring thing to say to people, is it? It's not going to engage their interest if you say you haven't read the papers. So we had to present the data, we had to generate better data, newer data, reframe the way the data was communicated through poetry and theatre and art, offer opportunities to interact with the data, disagree, and to always bring lived experience and experience data into the conversations to resolve disputes. And that's not an easy thing anyway. There are many varieties of lived experience. There's not complete consensus within the lived experience community either. We did use research as a powerful tool, as an authority, but we were aware of the limitations of using research as well. There are various papers you can look up on the website, Synergy Collaborative Centre, where we had to debate what racism was and how it affected mental health, what participatory methods were, how ethnic inequalities arise and how to resolve them. So I'm coming now to talk more about a specific inequality, that is the use of the Mental Health Act, originally developed in 1959, revised in 1983, revised again in 2007, and currently there's a review which has been completed, and the Act has been through a joint parliamentary scrutiny, but it's awaiting for action from whichever government comes into power soon. We're involved in a project for NIHR to look at this, and I'll tell you a bit about the results. This just illustrates the marked inequalities in the use of detention and compulsory treatment by ethnicity, and the data are consistent that black patients have higher rates of detention. The study is called COPACT, a disclaimer that the NIHR have been very kind in letting us share the preliminary data with you, but the views are our own and not those of NIHR or the Department of Health and Social Care. But before I present the data, I want to show a video which introduces you to the project and the way of working.
My name's Bobby Clark. I live in East London. I've been in and out of mental hospitals for the last 30 years. I've been sectioned a number of times, and I'm really, what can I say more than that? I'm a paranoid schizophrenic. I went through a real rough time.
The problem that we've found is that black people and minority ethnic people are more likely to be detained under the Mental Health Act, are more likely to be diagnosed with schizophrenia or schizoaffective disorder, and usually over-medicated higher doses and for longer periods. My name is Doreen Joseph. I'm working as a peer researcher at Oxford on the COPACT project. With COPACT, they have a unique way of investigating this subject. Participants would be issued with a disposable camera. They take pictures. The pictures that they take express what the experience of being detained has been like, what it means to them, how it affects their life, and also what they would like to see changed as well.
This is the local shop where everybody goes. We get Sainsbury's and Asda. This is the local shop, yeah? Oh no, this shop we love, community shop, yeah? I took some pictures of the moon, the sun. I took a picture in the shop showing that this is one of the last community shops in our area. Nature, some flowers, because that's nature giving us life. Because flowers like a new beginning, it's all the light inside. I like them things, I do. I really do. It might sound a bit silly, but I really like them things. I'm into nature. It gives them a bit of more insight into you, and that's where you're coming from.
Health Act means that people can get detained in hospital when their mental health becomes really, really bad. And we know that this piece of legislation impacts people from marginalised communities and from ethnic minorities in a different way. And that's something that we want to better understand and improve. We know these people have a much poorer experience, poorer outcomes, and are subject to a lot more coercive care. So Photo Voice essentially entails getting people to take photographs that represent their experiences and then getting them to provide captions to sit alongside and provide context to these. And this is a very different way of capturing experiences compared to traditional research methods such as questionnaires or interviews. This data will then inform a series of co-design meetings. And at these workshops, we'll get people from across the system. So that will include psychiatrists, chief execs of NHS trusts, paramedics, social workers, but also service users and carers, and people from voluntary and community organisations to come together and review the evidence locally about what the challenges are with regards to the Mental Health Act and ethnic inequalities, to get entangled with the images and really understand what it's like for these people. We wanted to feel like we were doing research with the people who this problem impacts. From the outset, we had people like Doreen Joseph be a part of the core project research team.
Yeah, so my background, I have over 30 years of being a service user. My diagnosis was schizophrenia. I've had good experience and bad experience, so now I know what good experience could look like, so I advocate for that. We have a role in ensuring that lived experience is throughout the whole project process.
In research, we often think about hard to reach or underserved populations, and you kind of end up in this perpetual cycle that we don't know enough about these people, but they never take part in research. But we don't know why they never take part in research, because they never take part in research. We wanted to do this research in a way that was accessible and facilitated marginalised voices. There's a lot of work that has to be done to shift people's thinking, even down to kind of the language and approaches that you use when trying to recruit a population that's never been asked to take part in research before. Whether it's technologically accessible, culturally accessible, or even pragmatic things like having workshops online in the evenings and on weekends if we've needed to, providing opportunities that facilitate people to take part rather than provide obstacles for them. We hope that in doing things the way that we have, in having such authentic stories in such a visual and creative way, that we'll be able to actually motivate change in these systems.
Being in COPAC, it was great because it gave me an opportunity to try different things, talk to people on a different level. It has given me like a bit of hope, where I can say to myself, you know what, there is a bit of help now for mental health people. It's getting better. Like, I pray to God and really do that it does get better.
Right. So, as you saw, that was a research project, but we have the same problem in research as we do in services. We can't get people into the right places and our concepts don't really work for them. And so all the evidence and all the interventions that are being developed tend not to apply to the people that we never see, except when they come in crisis and end up in the system in crisis. The feeling generally was this was really enjoyable. People really enjoyed participating in research. Now, that's not often people say that. They're tired by filling in hundreds of forms and asking deficit-based questions. They're often feeling worse afterwards than before when they've completed a survey. So this was a different way of going about it. And what we found striking was how powerful it was for the people themselves, such that they've stayed in touch with us and continue to want to work in research and in other projects with us. But also we've learnt an awful lot by working with them and being challenged by them in everything we do. This is broadly the outline of the project. There is a protocol published online if you want to look, but essentially we talked to 48 people. We wanted more, but ultimately 48 people with over 500 images produced and 32 hours of narrative. We also talked to 17 members of staff, and there was a focus group where patients were telling us about how they felt about the whole project. There's also an economics evaluation and an experience based survey as well, and there's a co-design process. Again, the findings of that will be reported. What I want to do in the last sort of 10-15 minutes is just take you through some of the images they generated, because the images and the captions for me speak the loudest really of all the possible things I could say to you. So they outlined the need for detention, interestingly. They said when they got detained, they needed to be detained. They accepted that. The problem was they weren't given any support long before they needed to be detained, sometimes 2 years before that. And they were put on waiting lists or ignored or referred to a service that didn't receive them. They felt professionals should take more time with their messaging because when they're acutely unwell, they need more information, they can't remember things. And there is evidence that when you're unwell, your memory processes are affected, but somehow we don't factor that into the way we share information. They felt coerced and threatened at times and disrespected and treated inhumanely. One participant talked about being transported in a black van. He thought he was being kidnapped, and there appeared to be no clear indication that this was a health vehicle. The image on the bottom right there symbolises the journey of being taken to hospital. The first time I was sectioned, I was taken to hospital in a black van. I thought I'd been kidnapped. And the image at the top there, essential for safety when psychotic and aggressive, you don't even believe family members are real. Admissions are essential to protect others and self from harm. So that, again, is an acknowledgement that you need admission at some point. I rang the police because I didn't feel safe. I felt invaded. I wanted the police to protect me, or at least know if something happened to me. But the police made it worse. I was worried about them raping me, more so thought they were going to hurt or invade my private area. It didn't help when they pulled my pants. I was wearing a pyjama down in the van. It would have been helpful if they'd explained what was going on. Instead of being detained in hospital, it's better to see the home treatment team. I prefer that because I'm still in the community. Being detained is the same as a prison because you're not allowed to go nowhere. And the pictures about exercise, it's good to exercise every day, good for your health, but when I was detained, I couldn't exercise for a while. These pictures are from staff. The cactus on the top right, I chose this as it looks quite soft and fluffy, but it's really annoying and prickly. I guess I'm not an OT trying to engage with service users by building relationships, gaining trust with people who are often very unsure and wary about trusting others. Trouble is in my role, I'm also there with my risk and safety hat on, and that side of things gets definitely prickly. There are two sides to what I'm doing sometimes, and that can be hard to reconcile. Fire extinguisher. Okay, so this is an effective and quick way of putting out an electrical fire and hopefully making it safe. However, it makes a lot of mess, and often the electrical things that was on fire is damaged pretty badly. There's a lot of clearing up to do. Things may not be quite the same after there's a period of anxiety afterwards. And then the wires, I feel sometimes I lose a good connection with service users. I've taken lengths to engage with. It starts to get more complicated, more messy with loose connections. Some additional reflections from staff. I won't read all of this out, but on the bottom left, an awareness that they were admitting someone who really didn't want to be admitted. They were very frail and fragile, and that was probably the last time they were ever going to be in their home. And then an awareness also what happens to children, of parents who are being detained. Seeing a parent being detained is an adverse risk factor for future mental health, coupled with other risk factors. And what happens to pets? They're very important. A lot of social workers do look after their pets, the pets of people who have been detained, but it's not statutory. There's not some sort of policy that says they must do that. They were very powerful. We just synthesized all the data using thematic analysis. And I'm not going to mention all of the themes, but essentially there were lots of preventive opportunities, how the detention experience could have been improved, and opportunities for supporting people in the community. They wanted information. They didn't want police escalation. Sometimes the police were used to, they felt, punish them, or it was escalated whilst they were in hospital. It shouldn't really need the police involved at that stage. Again, topical, given the police have said they don't want to be involved in mental health care assessment at the moment, and have pretty much said they're not going to be involved. At the time of detention, some said it was very traumatic in a way that it changed them forever. They'd never received any therapeutic intervention for it, and they wanted that and support into the community. They wanted more family support. They wanted staff, interestingly, to be skilled and care for them. They recognised how difficult it was. What they couldn't understand was why they weren't the right staff in the right place looking after them, and why they had to deal with so many injustices. So we're very compassionate about the staff, in fact. I want to introduce our colleague, Neil Armstrong, who's written this marvellous book, Collaborative Ethnography, Working in Mental Health. And Neil has unpacked a lot of these issues. Neil himself suffered with illness, and the book is written by him and other people who suffered with mental illness, but they've also worked as professionals in the system, so very, very insightful. And he talks of the double register of care and compliance, control and restraint, medication default being too easy. There were institutional bureaucracies and simplistic bureaucracies and models of mind that were used. And when there's emotionally demanding work, there's conflicts and hostility. Neil didn't buy into Foucault and power only being important, but really very much said, look, there's a system problem here, a bigger system problem. The organisations, the bureaucracies we work in have several difficulties, and we don't have the language to explain these difficulties. We think we're on our own. So he introduced some terms in his book. Cubism, I thought, was a nice term he suggested we use. As in, there is no perfect, meaningful, overarching aesthetic to what we have to do to solve the problem. That we were expert at delivering the disciplinary project of the state rather than providing care. That we were methodologically detached and disorientating. We traded in secrets, that people knew what was going on when you talked to them in private, but in public settings they didn't. The term secular theodicy used. Double morality and bullshit, posed by a philosopher here, and as a way of describing insincerity. And I guess what came across was that we all know the problems, but we're powerless to fix them as clinicians. Even in the staff reports, they were aware of their inability to do what was required sometimes because they were following legislation and doing what was required to be compliant with legislation rather than what they thought they could do and offer as an alternative. So I'm going to end now just thinking a little bit about some of the challenges I've posed and difficulties, and I've talked about collaborative leadership as a part of the solution. I don't mean a sort of leadership from the top. I mean it's everybody's business. That actually we all have to have the emotional intelligence and the skills and the awareness, the self-awareness of our own positionality in our cultural biographies, or transfers and counter-transfers in psychoanalytic terms. That there are these latent group identities, and the problem becomes one of identity if we don't think hard enough. And Volkan and Alderdice both have worked in conflict zones and with terrorism. And in these moments of crisis, there are breaks in our thinking and our linking, psychoanalytic term from beyond. And we're unable to function. We need to move more to the experience near and not always rely on reason and rationality, because often these things aren't reasoned or rational at all. They're responded to in terms of power and structures. But it was important to build coalitions across diverse ideologies. And the term psychopolitics from Fanon and Cedric, if you wish, I thought were powerful terms also to draw in, to understand that there are psychological aspects to power in systems, but also that resistance and protest needs to be psychologically informed and emotionally informed in the way it articulates its arguments. And as I said at the beginning, for every group there's an anti-group, and working with that is not easy when you're in positions of authority and power, and sometimes people at the top of the organisation struggle with this as well, because they just want to get on with the job and fix things. In summary, experience data are essential. I call them data because they tell us about the real world. They're not just subjective experiences, they're telling us what's really going on for someone. There are systems and structural solutions and collaborative leadership. We need courage, we need to tackle epistemic injustice, we need to trust non-linear solutions sometimes, that we can't expect and plan for everything that we do, and there are unpredictable events which sometimes turn out successful and sometimes not. So again, our way of measuring success in our bureaucracies don't really serve the purpose sometimes, and is it time to think very, very differently? There are a range of projects we're running using the same model, experience data, multiple types of methodology, combining experience data with statistical data, but leadership and interdisciplinarity and power and coalitions are part of all of those projects, and on very different subjects. Thank you very much. I've taken the full hour.
Hello, thank you for your talk. That was really interesting. So there are so many problems. If you could play God for a day or a week, what do you think are the 3 changes that you would like to do that would make the most impact in our healthcare system?
One of the enemies of success is pessimism and being intimidated by problems. So I think we shouldn't be intimidated by the problems that we face. These are real world events. And because of the complexity, there are no simple solutions to anything that we do. But I think including experience data in everything that we think about and do, and dismantling epistemic injustice, both in practice but also in the way we gather evidence and decide how we're going to deliver policies, is probably, I think, where the answers are to really unpack. If I go back to my penultimate slide, these components, I think, but it needs leadership at every level with people who can operate in this way. And this isn't something you learn. It's not a CPD course. It's not an online tick box training, which we do for mandatory training purposes, and we're compliant and we get, it's not that sort of, it's a learning process that people have to commit to. And that means it has to come from the top, from all parts of the system, and people have to be able to do that. So it's not an easy answer, I'm afraid, but your question was interesting because pessimism is one of our biggest challenges.
Hi, my name is Zishan. Thank you for a really thought-inspiring talk. You mentioned it briefly about these categorizations of racial groups and how they have their own limitations. I just wondered how you go about recognizing the heterogeneity of experiences within particular communities. How, for example, when it comes to the Mental Health Act, the people that are detained tend to be people from with very intersectional factors. So, black individuals, it tends to be black men, people from poor backgrounds, for example. How do you acknowledge that intersectionality while still advocating for the group as a whole?
Yeah, so as I said, I think most of the difficulties arise at the intersections of multiple disadvantage. Ethnic categories, we know are flawed. They are there to count types of people and actually are very colonial in their construction, really, in the way that were originally used. But there's so much heterogeneity, and race, we know, isn't a biological phenomenon. It's a social phenomena. There's more variation within any race than there is across racial groups, but it seems to count for a lot as a social variable. So on the one hand, we're trying to generate data, all the ethnic inequality data, to say if something isn't right, that we understand our system. On the other hand, we criticise the categories because they don't really work. So the way I've thought about it is ethnicity is a process, it's not a category. And it involves multiple dimensions of disadvantage. And for some, it's a proxy. For some, it might be more closely related. So if it's racism you're dealing with, then it's a more closely related variable to the adversity. But if it's ethnicity, it's more difficult. And even within religious groups, there's marked variation of acculturation and health literacy and people's willingness to adopt particular types of care. So what it comes down to is being aware of that complexity, both in the clinical task, in the management task, in policy making and in legislation. It's not easy. So part of our job is always to try and communicate this. And of course, having to use script sometimes to simplify and be persuasive and to encourage action where we think it's going to make a difference. Based wherever possible on evidence, but sometimes based on the best evidence available at a particular time to act in the most appropriate way. But your point is well taken in terms of the limitations of race and ethnicity.
Hi, thank you so much for your contributions. I'm interested in how you guys go about researching. So I am really pleased to see the creative ways in which you guys get information from participants, but how do you go about getting more of that? I remember you said that you wanted a certain amount, but you only got a certain amount of people. How do you go about getting that and getting a fair representation of people within these marginalized communities that you're looking at?
Yeah, very, very good question. So I've committed, the work that we do in the group that I've called Chimes is committed to interdisciplinary work, and we're trying to unpack these ecosocial and syndemic frameworks in mental health care. All our projects that I've just put up there again involve some element of creativity, some element of interdisciplinarity. That's not easy, by the way. That's challenging in its own right. But even though we secured only 48 people in the COPAC study, they were the right people. They were the people who would never participated in research at multiple intersections of disadvantage. Something worked. So we are trying to learn how to do this better across the piece. And so some of the elements of the project actually looked at, if I flip back to one of the slides that we had here, we did include a focus group looking at recruitment experiences, and what we found was that in particular places, the infrastructure which was supposed to be there to support people into the study wasn't as strong or as able as it should have been because of a lack of resource. Broadly speaking, the northern sites, who were very, very committed, just had less capacity to support recruitment. So we had to do a lot more work. Sharing the knowledge, encouraging people to tell other people about the research. Our own participants continue to be involved in multiple projects and other research projects, but also tackling some of the challenges of doing interdisciplinary work and these creative methods. It's not easy. There is not a roadmap for how you combine photo voice data with narrative data and what sort of analysis you undertake. Yes, we've taken lessons from certain texts and chapters, but we've had to describe the methodology. So I think the other thing we need to do is improve the tools and resources for other people to make use of our learning. And that's happening across all the projects, particularly, I think, most strongly in a project called Attune, which is looking at adverse childhood experiences using all creative modalities, dance, theatre, music, and Origin, which is developing a digital online museum using stories from people from diverse parts of the world, as well as photography, as well as other means. The challenge of multidisciplinary work is nobody feels in charge. Nobody feels they know what they're doing. Nobody feels they have power. It's quite good, really, for doing better work, I think. But it's hard to do because we all want to do what we think we're good at. We don't want to waste time doing things we don't think we're good at. But you have to in interdisciplinary work. You have to knuckle in and take the time to do the learning and acknowledge that it's an imperfect way to work if you are very purist, but it's not in other ways. I mean, I trained as an epidemiologist originally, and originally did pharmacology as a basic degree, so you can see the spaces I'm in now are very, very different. And all the anthropology and sociology I've learned is working with other people and not claiming that I am an anthropologist or a sociologist or a philosopher. So there are ways and means, but it needs people to work in that way.
Thanks for this. Quick question, which is, what's been the biggest change in the last 2, 3, 4 years that you've been most impressed with that's solved problems here?
So I mentioned an awareness of the scale of the problem, and there are probably two things. One is the recognition of lived experience data being central to transforming our systems. Sometimes that's a little tokenistic. We did a study looking at how lived experience entered improvements in care, and generally it didn't. Scott Weiss led that study. The second thing is nothing to do with us. It's COVID and Black Lives Matter. It's so interesting. Suddenly, people started listening to the messages. Suddenly, people started becoming aware of their own conditioning over generations and decades about how racism operates, about structural disadvantage operates. It's not uncommon, it's not an uncommon piece of knowledge, an unknown secret that some of the biggest health interventions have got nothing to do with health. They're public health interventions and societal interventions. And public health is really about how we organise society and the societal efforts to improve people's well-being. So I suspect that's where some of the solutions also are, that without changing those structural attitudes and perceptions and views and the way we organise our systems, the way we think about health, the way we think about mental health, things won't change. And there are some contrasts between countries which are also interesting. Going back to your ethnic category question, if you're in France, you can't ask about race and ethnicity, you can ask about migration. You have to structure what you do within the political context, understanding what you can and can't do to do what you need to do. So it's a bit of a challenge in all way. But that's the sort of leadership we need, who can manage these concepts and manage these nuances.
Thank you again. I work with an organization that does training for public servants and policymakers, and kind of getting to your final piece around building a strong collaborative leadership in people who can make the kinds of decisions that influence these things. Like really practically, you said very explicitly, it's not a tick box of an online course or anything like that. How do you suggest we kind of get to places where that is embedded in the culture of people who influence these things?
Yeah. So I think we're at a stage of probably pre-competency. People are aware there's an issue and they're not sure how to tackle it in most places. There are some exemplar sites that claim they've solved the problem, but the majority haven't. I think you have to take people with you. So it's a question of whether people are ready to engage. I don't go around telling people what to do, but when people are ready to work with us and seek support, and we're happy to help. And getting people to that point is quite challenging, quite difficult, where people actually acknowledge there is a need. I've mentioned some of the sort of responses I've had over time, from people. They probably still happen. People don't see the need. They're too busy. They're pressed. I've described how the work conditions that people have make it hard for them to think beyond what they have to do, what they must finish on. But I think it is important for all leaders, policymakers, managers, to commit explicitly to want to tackle this. In a way, the Mental Health Act has offered an opportunity. Changing legislation isn't going to fix all of this. I think we all accept that, but it does signal a changed relationship between the service, patients, the state and society. It indicates something if we change the language and change the safeguards. And therefore, for the legislation to work, you have to have the right system around you. A part of your question was policymakers. Now, policymakers have a really difficult job. They have to work with governments who have very narrow windows of attention, and everything's a priority. We're very fortunate in that this was commissioned by an NIHR policy research programme, and so we have their ear when we're reporting, and there are 3 other projects like this looking at the Mental Health Act. And my way of working is generally to stay connected, informed, and be kind, and talk to people who are in positions of power and influence, but recognise where they're coming from and give opportunities to share the data, to share the information that we've generated, and try and help solve problems as we go, because it's hard for policymakers as well to be able to do everything that they want to do. Normally there are critical windows, which is why the mental health legislation is so important. It's given us a critical window to really re-examine the system.
Let me shift the focus a little bit. One of the things that you showed that shocked me the most was the first-person report on a person being taken away in a black van and nobody explaining what was happening. And so a lot of what you were saying was to do with systems, but I just wonder how much of the negative experiences of being sectioned are owed to systemic failure, and how much are owed to people not fulfilling their professional roles properly that the system allots to them. Because I can't believe that, I mean, maybe, I don't know, but it sounds improbable that when people are trained to take part in that kind of process of applying the Mental Health Act, they're not instructed to say, look, this is what I'm doing, this is why this is happening to you, or to use a van which makes it clear that they are professionals rather than kidnappers.
Yeah. It is alarming, isn't it? So I guess we can reflect on whether some of the films I mentioned, still live and exist in our institutions, really. People are generally extremely well trained and very compliant with what they're asked to do, but there may be minor variations of that. Usually that works well. If someone's detained, there are 2 doctors and a social worker. In a crisis, if police are involved, if there's an emergency, you might see a different level of sensitivity to what needs to be done at what point. And generally the police are really wonderful and sympathetic and manage situations very well as well. But it's very difficult in a crisis to make sure everything is done. When I've been assessing people at 4 o'clock in the morning, it's very hard to think of a lot of other options other than to admit and see what's going to happen, particularly if there are concerns. But I do think the system and the structures shape, condition, reward and punish particular sorts of behaviours. They reward the compliance with the system must-dos, ticking the box which tells you which diagnosis you've got, making sure you fill in the forms. But they don't necessarily reward the things that are more important sometimes, which is taking time to explain, recognising the person isn't processing information well enough. And that actually we know their information processing effective when someone's acutely unwell, the memory's impairment happens and trauma leads to altered autobiographical memory, but we don't take the time to explain that. So it's having to reduce what we must do to something very basic, which is what we're trying to think of as the next sort of stage of intervention. But I do think there's a link, and I think our awareness of that link and the recognition of that link is difficult for people. It's difficult because every organisation works in a similar way and they're expected to do similar things and use metrics in a particular way. So it would require a radical departure from that. There are variations. There are models where they try not to use inpatient beds or detain people forcibly who have different lengths of duration of detention. So there are different models of mental health legislation. We just haven't spent enough time, and I just think it's very easy as a default option when anything else in the system fails and there's a bit of risk involved that someone's detained. That's kind of what I think is happening, and that's when all the niceties disappear.
My impression of the system is that it's actually just reduced to risk management, and that's about all there is left to us in this country, and that there are massive cohorts of people who desperately need help with their mental health, who have serious problems and cannot get that help. You said recognising people. There's also the sense that the system is just doing tick-boxing exercise and that's it. And if you don't fit in a box and they can't tick it for you, you don't get any help. So when you talk about groups of people, and where you have been today, you still, at the end of the day, once if you can do something about that issue, you still have to get down to the individual level, don't you? And we're so far away from that in terms of the actual system and what it's actually providing for people. I mean, just to talk of the numbers of people with, adult survivors of ACEs, there are thousands, if not millions of them, who are in desperate straits and can't even, the health service doesn't even recognise them as being a category they have to tick a box for. So I just wondered how you feel, this is great stuff, how you feel that can pan out in reality in what seems to me to be a sort of fossilised institution that is just there existing just to answer a sort of perceived social need to keep us safe from people who have got a mental health problem. And there's no actual direct connection and human value in it for the people who have got the problems. Sorry to sound so negative, but...
Yeah, no, I hope to lift you up a little bit, but let's try. So people entering the health professions or social care, do so for very good reasons, and they're very good people. But we know by the time they're at the end of the training, they're quite different people, and they've learnt to be a technologist. They do care, they try and do their best. And it seems that that gets worse over time. You can't get away from the fact that there's a lack of staff, there's a shortage of staff, people are working in crisis, the facilities aren't there, the resources have got worse, the actual demand has gone up as well, or the recognition we need to do more. So I think what happens is people survive and do what they can in a default situation, and that's when compliance becomes important. Sometimes the institution doesn't recognise, well, giving you more perverse incentives, it's making the problem worse. So that by giving you extra paperwork or audit metrics to fill in or outcome measures, or that actually you're spending time doing that instead of working with the person. I think people are aware, this double register, this, what did Neil call it, social theodicy or something, that actually people are aware, and that's why they're not happy themselves working in the system, and that's why there is a shortage and people are going off doing other things because they're not valued. There is a recognition, actually, if we're brutally honest, that we cannot afford the health system to be totally supporting everybody in the way they want to be supported, and I think that realisation is making people think harder. So there are priorities, adverse childhood experiences, long-term morbidity, but prevention, public health and self-care has to be the priority for the coming decades. The problem with that is you don't see outcomes as quickly as you do with other sorts of emergency interventions, and it's certainly not in the lifetime of one parliament, or two even. So you'd have to have people committing politically to something they're never going to see the benefit of, and maybe is a hard sell. I think the awareness is growing, and I think the lived experience world is contributing to that. But it is very, very controversial, and there is a lot of conflict out there about what the system does. So, and what psychiatrists do and what psychologists do, and there are critical psychology and psychiatry movements, there are anti-psychiatry movements, there are all sorts of, everything's refutable, nothing's evidenced anymore. So the evidence base itself is insufficient and poor. So I anchor most of what I say, and everything if possible, in evidence. I just expand the form of evidence that I'm trying to argue with, but also recognise the dilemma people have in their day-to-day jobs. And so, for example, meeting with commissioners and policymakers, or in places which allow them to think differently, in which they can be free without the pressures that their institution imposes on them, is challenging, is difficult. But that's another psychotactic, to use emotional and creative methodologies to actually involve people in things that are pleasurable, to use aesthetics to combat the trauma, to combat the negativity, the pessimism. Because for a long time, this whole area of work was beleaguered by pessimism. It's too difficult, let's not bother, let's do something easier, we can show the metrics for that. It's such a challenge, particularly for young people whose waiting list sometimes can be 2 to 4 years. That's a long time in a young person's life. Lots happened in that time. It's very, very difficult. We don't have a system fit for purpose at the moment, but there's a lot of people working very hard to do it. But it needs this sort of awareness and understanding for the right solutions. Otherwise, in my left-hand box there, we keep making the same errors. We keep doing the same thing. We keep introducing metrics. I've got to be careful, I'm not party political here, but you might be surprised to know which parties are still wanting reform. We've had so much reform, but people aren't really listening to either the patients or the staff. The staff in the study themselves were pretty much aligned with what the patients were saying about what goes on. They just had a different way of having to compartmentalise and deal with it and do what was necessary. And the patients are aware of that, hence the sense of insincerity, that they're aware, the staff are aware, but no one's admitting it. And so you live in this world of secrets. Honesty, I guess, and truth is what we need more of
that, great talk, pleasure to listen to. I'm a technologist myself, engineer. This may sound like a bit of a loaded question. You look at AI, it has its biases, even though a lot of things nowadays are data-driven, it does have its biases. You look at technology in itself, you look at social media and the impact it's having on the youth. You say it takes 3 to 4 years for kids to even get into a place where they're getting therapeutic care or any type of even seen. It's two questions really. First one, how do you see the increase of technology in society affecting the job you do and the challenges? As I say, a lot of things are now going more technologically based. From an ethical standpoint, in my opinion, it's also creating a divide. When you talk about colonialism, it's creating a divide both locally and internationally. How do you see that changing the job you do and the importance of getting this message across in a timely manner? And also, what can be done, second question, sorry, a bit loaded, what can be done on a micro level, for example, ourselves locally, to increase that awareness, or what can we do to get involved at a local level to be able to help make those changes and, I say, bring about change for the many and not the few?
Very good questions. Technology, you can't hide from technology. It has two sides to it. People are using technology more and more to try and support care systems, and there are all sorts of pilots and research studies going on about the use of AI in predicting trajectories, in better classifying people into groups that will benefit from this sort of care rather than that sort of care. There is this idea that somehow technology can do this better than humans because it's unbiased or unsupervised. But you, as you've said, whoever designed the technology is biased. They have a positionality in the world, and so you could get similar sorts of outcomes out. The other problem we have with technology is, do clinicians and do the public trust it if they don't know quite how it's come to that conclusion? And misclassifications of technology, again, very topical in light of the post office crisis. You know, how do you respond to that, and will people be willing to use it? Technology is increasingly used by young people, and it's almost certain it's influencing the way they think and relate to themselves in the world, their identity, the sorts of access to support they have, but also the vulnerability to adversities and trauma they have. So that's something we do have to acknowledge and face. But we have to embrace it. It's not going away. It's so interesting. I had a debate with my daughter and my niece over the weekend exactly on this point. They did think I was a dinosaur, but we discussed it at length and trying to draw on different perspectives. But they were trying to communicate how we have no idea of how immersed they are and how conditioned they are to using technology in a way that we were never exposed to. It's not an option to switch it off. It's not an option to not use it. It's not an option to try and modify it, because their whole world revolves around it. And positively, that means they will be using it in a different way. We'll see ways of managing problems that we can't see. So I think it is a solution, but it is a problem as well. So I've forgotten your second question, just briefly, if you remind me.
Second question was, and what can we do on a micro level, as I say, ourselves, in order to be able to help make that change?
So it comes down to people being motivated, interested, wanting to get involved, getting entangled, which is what I think the artwork and the narratives offer. They give you a very human experience, that you see somebody else, which a health system doesn't always see. They see a condition and a problem to solve. And I think be part of your local movement. Wherever you live, there'll be a trust board, there'll be a local health service, there'll be a local community group. Get actively involved and listen and support. And you'll be amazed. A lot of the collaborative leadership model that I've described was about just holding hands, supporting people in times when they're feeling a bit stressed or underconfident, about making a pitch for something they want in their service. And also noticing when power dynamics get played out in committees and meetings and decisions are made that aren't acceptable. It takes a lot of energy, a lot of effort. You know, it's draining, it's exhausting, it's emotionally demanding work, which is another reason perhaps we don't do it. But it means recognising that, and that everybody is involved in the process. So a critical step is to convey this knowledge, convey the problems in a way that it's digestible, that it's not intellectually opposed, that somehow people find it uncomfortable. And I again go back to COVID and the way people are talking about racism and race. Not everybody, still people still oppose it. There is an opportunity to continue those conversations, but it has to operate at community level, I think, and families and schools, but also at an individual interpersonal level, that when clinicians interact with people. People should also be much more aware of their rights, as they would be on admission, for example, but in the community more generally, about how they can improve their experience. Otherwise, we're all disempowered. It becomes a pessimistic enterprise. Generally, our public systems are emotionally demanding. When you try and negotiate welfare, you try and negotiate anything, it doesn't matter how capable or intelligent you are, it's demanding. So when people are living in precarity and their emotional resources are already drained, they're going to not do the right thing at the right time, and then we penalise them for it. So there's a whole awareness of this problem that needs to be in public services and in communities.
Well, that note of qualified optimism is perhaps a good place at which to end, but we have to end anyway because we're out of time. So thank you very much for all your questions, and Kam, thanks so much for the talk.